walk you through an important aspect of why accurate documentation is important from the hospital reimbursement perspective. To understand that, you need to know what is DRG, MCC, and CC. So CC means or stands for complications and comorbid conditions. MCC stands for major complications and comorbid conditions. And basically, the hospitals are paid by Medicare and other major insurance companies based on what is known as DRG, or Diagnosis Related Group. A DRG will lead to higher payment to the hospital if it has a CC in it than a DRG without a CC. And a DRG with MCC will be reimbursed even higher than a DRG with CC because it implies more complicated case. So let's take the common example of heart failure, and probably you receive a query or more from documentation and billing staff asking about some clarifications about that diagnosis of heart failure, and maybe some from other common conditions like we see in the next few slides. And here's why. So let's assume that you are taking care of a patient with hypertension and chronic kidney disease who is admitted for heart failure exacerbation, and this is what was documented. So in the documentation, it's mentioned that the patient is having CHF, hypertension, and chronic renal insufficiency. That's kind of the main language or terms used in the note. And when the hospitalist bills, they're probably gonna relate to these documentation diagnoses. So it's gonna be like CHF unspecified, hypertension, and chronic renal disease. And all the three, if they were mentioned like this, basically it's a non-CC or a non-complication in comorbid conditions. It doesn't really reflect the severity of the case. And that will lead to what is known as the case mix index. The case mix index is a relative index that the Medicare and other, it's mainly Medicare that use this term to kind of have a relative weight for each DRG or for each diagnosis to reflect the severity and complications of these DRGs or cases. So a case mix index or a CMI of 1 indicate this is kind of an average severity illness or diagnosis. Anything above 1, the higher the CMI above 1, the more severe the case and the more complicated the case, and the lower than 1 CMI indicates less severe case. And Medicare and the government uses this as a kind of for also not just reimbursement but also for allocation of resources, so that hospitals who are taking care of more and more patients with higher and higher CMI, they should receive more support and more reimbursement because they're taking care of more sicker patients. So in this specific scenario, based on this documentation and diagnosis, the CMI will be reflected as close to 0.6 or 0.7, which also indicate that the average hospital stay for such patients should be only 2 to 3 days, and that will lead to reimbursement for something about $5,000 to $6,000. Now, with the same patients, when you get a query about they ask you for more specific and accurate documentation for the same patient. If you documented in the right way and wrote something like acute systolic or diastolic, depending on what the patient has, heart failure exacerbation with moderate bilateral perfusions, if they have that, due to hypertension and associated with chronic kidney disease stage 4. So as you see, this is more accurate, more specific documentation, and this will lead to diagnosis with more MCC and CC in it. So for example, acute systolic heart failure exacerbation is an MCC, pleural effusion is a CC, CKD with a specific stage like stage 4, which implies like an advanced CKD, is a CC. So that will lead to a CMI or case mix index of 1.5, which is much higher than 0.6 or 0.7, and that will indicate that the patient should stay probably in average from about 4 to 5 days, and that ultimately should lead to reimbursement almost double of that first documentation. It would be about 13,000 to about 14,000. So as you can see, really kind of documentation can really make a lot of difference, and that's why one of the reasons why the hospital will really kind of look into the documentation by physicians to make sure that they really truly reflect the severity of the patient that they're taking care of, and I think that's very fair. I'm going to give you more examples to maybe hopefully demonstrate that better. If you get a query, probably it's going to fall under one of these common diagnoses and conditions, but there are more. But I think these are the most common one. So for example, alternative status, they might ask you to clarify if you think the patient is having delirium or even better, acute encephalopathy. And if they do, document what type of acute encephalopathy you're suspecting. Is it acute metabolic, acute toxic encephalopathy due to pneumonia, for example? So basically, what's the underlying cause of the encephalopathy? And I think that's really more accurate and more scientific. Also, respiratory distress is not enough. You need to document whether you think it's acute respiratory distress, chronic respiratory distress, you think it's hypoxic respiratory distress, or hypercapnic respiratory distress, with some documentation about some of the clinical features that make you suspecting that. In addition, for example, to documentation of an O2 that's less than 90%, for example. Just more data to support your documentation. And if your patient with COPD, they're on home O2, that's a chronic hypoxic respiratory failure.